My name's Taylor Hyatt. As Amy said, I'm a policy analyst and outreach coordinator at Toujours, Vivant, Not Dead Yet. I'm going to go over the results of our survey on what has been happening with assisted suicide, euthanasia, and other life-ending practices in Canada so far. Our database currently has 13 entries in it, so this is just the very beginning, the tip of the iceberg with the most obvious issues. So let's begin with a breakdown of the demographics. Who seeks out assisted suicide and why? Most of our information comes from news stories, so they reflect the population whose desire to end their lives is most likely to get media attention. As my American colleague Stephen Drake has said, they tend to fall into 4 categories, all starting with W. They tend to be white in ethnicity, as all of the people in our current database are. They tend to be well off, although 2 people in our survey identified as having job security issues or lower income. They're usually well. In other words, they don't have an illness or disability, or they've acquired a disability later in life and haven't yet integrated it into their self-image and how they perceive themselves. Finally, they're worried about what the future holds. So in order to be eligible for assisted suicide or euthanasia at all, the person needs to have some kind of illness or disability. And disability and the barriers and discrimination that come with it are poorly understood, dreaded, and even despised by many. 12 of the 13 people in our survey had disabilities and 1 had a chronic condition. 11 needed some kind of accessibility accommodation, and the situation of the remaining 2 wasn't clear. 10 were wheelchair users and needed suitable housing. 5 needed accessible medical equipment. 2 people needed communication assistance to help them express themselves. Another 1 needed help to understand information that was given to them. 8 needed in-home personal assistance. We'll come back to this later. 2 needed breathing assistance. 1 had feeding supports. 1 needed accessible transportation. 1 needed information to be given in plain and simple language, and 1 needed better pain management. As Amy said earlier, the monitoring regulations fall far short of what they ought to be. Doctors don't have to ask about circumstances like these when examining a person's request, except to note whether the person required disability support services, for how long they've been received, or if they were not received, are they available and did the medical practitioner know about them? Another factor to keep in mind is that some of the people in our survey acquired their disabilities as adults. Of course, when this happens, it's a lot to deal with. A period of grief and adjustment is natural and normal, and reactions of family, friends, and medical professionals also strongly influence how a person adjusts. And when these people view disability in a negative light, their judgments get in the way of the adjustment process. This is especially true for the folks who needed feeding and breathing supports. Many non-disabled people believe them to be limiting, unpleasant, and incompatible with a good quality of life. Another point that should stand out is the age range, which ran from 20 to the late 60s. Why so wide? Besides traditional non-assisted suicides and people who ended their lives using the government program, our search also revealed mistreatment of people with disabilities and people who contemplated ending their lives due to a lack of supports. In particular, those who acquired conditions later in life may not have known about accommodations or been able to access them. Everyone in our survey also belonged to some kind of disadvantaged group. Besides having disabilities, there were 4 women, 1 person of a lower income, and 1 with job insecurity. Women are more likely to be euthanized due to gender-related issues like poor pain management, limited access to health care, higher poverty rates, and sexist expectations that they put their needs last. As I mentioned earlier, all of the people in our survey were white, so racism wasn't a factor, but we have reason to be concerned that it has played a role in other deaths. We know that people of color regularly receive poorer and less medical care relative to the white population, and they're underrepresented among medical professionals. More specific to Canada, our country has a history of bias against Indigenous groups, and the lack of resources available to them even today has resulted in a 5 to 10 year gap in life expectancy between the Indigenous and non-Indigenous population. As far as pain management goes, Indigenous children are known to have higher rates of chronic or disease-related or dental pain, and they're more likely than non-Aboriginal kids not to be treated for the pain that they have. On a related note, we know that 11 people definitely received healthcare services in their first language, and we're not sure about the remaining 2. Finally, 6 people had no ties to the military, and we're not sure about the veteran status of the last 7. What we do know is that veterans have a suicide risk 1.4 to 1.8 times greater than the general population. And disability, chronic pain, brain injuries, and psychological conditions have all been identified as risk factors. What about applications to the government euthanasia program? 5 people wanted assistance to end their lives, 6 did not, and the other 2 aren't clear. 4 people made 1 application each. 3 people made multiple applications, all of which were denied because they didn't meet the reasonably foreseeable requirement, which is being challenged through the courts in 2 provinces right now. 2 people were offered death by a medical professional, contrary to the criminal code, which says that doctors are not supposed to encourage anyone to seek out assisted suicide or euthanasia. The discussion has to be started by the person who wants to die. And there are another 2 people in our survey who took their lives before the current law came into effect. Among those who wanted assisted suicide and euthanasia, here are some of the reasons behind the requests. 2 people found their inability to engage in enjoyable activities unbearable. 1 cited a loss of dignity, but living with breathing or feeding assistance or any other disability supports does not take away your dignity, does not make you any less human or worthy of life. 3 were isolated or lonely. 1 was concerned about being unable to perform everyday activities, think cooking or running your finances. 2 had inadequate pain management. 2 had other symptoms that went unaddressed. 2 cited lack of control of bodily functions, with their situations violating the false social construct that says retention of bodily fluids is necessary to be considered a whole human being. 2 didn't want to live in an institution like a nursing home, and there's 1 for whom we're not sure. Quick rundown of nursing homes. You might be wondering why they're so awful. People often live in institutions because of lack of resources to live in their own homes. These facilities are unsanitary, in poor repair, understaffed, and have high staff turnover rates. Nursing homes restrict the choices available to their residents. So imagine your meal times, the times you use the bathroom, your bedtimes, all set based on what is best for the staff. Your baths may be limited, and you might even have rations on something as simple as toilet paper. When residents complain, their complaints are dismissed as trivial, and we've found numerous incidents of neglect and abuse by staff and between residents. A variety of medical conditions were represented in our stats. Neurological conditions were the most common diagnoses, think ALS. 3 of the 13 people had those. 1 person had cancer. 1 had a cognitive disability and another had a psychological condition. 2 were listed as having a physical disability, including 1 person whose pressure sores went untreated. 9 people had received some kind of treatment for their condition. 1 had not. 2 people were being denied the care they needed, and again, there's 1 whose status we're not sure of. Life-sustaining measures didn't apply to most people, but 5 had received such care. 2 people had feeding supports, and there were 3 in total who had breathing supports. 5 people owned or rented their home. 4 lived with family. 1 lived in a nursing home, 2 were hospitalized, 1 was homeless. And here's a breakdown of those necessary home-based services that people needed. 1 person needed care from a nurse who visited their home. They did not get it, and another 1 received it. 3 people needed mental health supports that they didn't receive. 3 people required modifications to make their living situation accessible, and 3 more received them. 1 person was in need of homemaking assistance. 1 person received it. 5 people needed personal assistance at home, self-directed home care, and 1 person received it. Of those who needed help with their personal care, 7 received this assistance from unpaid family members, 2 received it from an agency whose staff visited their home, and 4 received assistance from institution staff. And the issue with family members is that they might know you very well and understand your needs, but have expectations and schedules and other responsibilities of their own. On top of that, because they are serving as both assistant and loved one, those roles might clash. They may end up resenting each other, or one role might take up more time than the other one. And it's situations like these that contribute to the common view that life with a disability is awful and a burden. What about palliative care and relief of unpleasant symptoms? 3 people needed better pain management, 2 needed relief from other symptoms, and an additional 3 needed support for a psychological condition. 1 person needed counseling to deal with their grief, and 2 would have benefited from peer support, because nobody quite understands life with a disability or medical condition like someone else who shares it. 2 people were offered relief from pain or other symptoms. In 1 case, it was discontinued, which contributed to the distress that the person was experiencing. 2 people received symptom management at home. Another 2 were looked after in a hospital. 4 people just didn't need palliative care, and 2 needed something else, like that in-home assistance. On to the actual applications for euthanasia and assisted suicide. 4 people filed a written application for euthanasia, 8 did not, and the status of the last one is unknown. Everyone in our survey, thank goodness, was over the age of 18 and eligible for government health care. And one of the most basic facts to know is that you don't offer assisted suicide to a completely healthy person. It's always going to be discriminatory because you're only eligible if you have a disability or other health condition. Which 12 of the 13 people in our survey had. The most important criterion under the law as it stands right now is the grievous and irremediable medical condition. So 12 of the 13 people had a serious and incurable illness, disease, or disability, and we don't know about the last one. 7 people had conditions that were in a state of irreversible decline. 3 were not. We don't know about the other 3. 4 experienced enduring and intolerable physical or psychological suffering that could not be relieved. 5 did not. We have no information on the other 4. And only 3 people in the survey could be said to have a reasonably foreseeable death. 7 did not, and we don't know about the last 3. Once the applications were submitted, and once these criteria were examined, did the medical professionals dig any deeper? We only know that one person's ability to understand information, evaluate risks, and express their final choice was properly assessed. There were 4 people for whom this information isn't known, and in 6 cases this information wasn't collected. 2 of those 6 took their lives before the law came into effect. And again, only once was potential impairment of the person's decision-making abilities explored. It could be caused by depression, prolonged periods of suicidality and distress, substance abuse, untreated pain, or poor self-esteem. 8 times these factors were not looked into, and we don't know about the other 4. Pressure from circumstances, which is the external pressure that Amy mentioned earlier, was definitely overlooked or ignored in 9 out of 13 cases. For example, isolation, living within the limitations of an institution, abuse, financial issues, or other needs going unmet at home. For 4 people, the stories didn't make this clear. Suicide prevention was not offered to 7 people, and it's unclear whether the other 6 received any intervention. 3 people received the assistance they needed to communicate, 4 did not, and communication supports didn't apply to the remaining 8. Here's some more miscellaneous information about the requests. Only 1 healthcare professional made sure all of the eligibility criteria were met. 3 times we know the practitioner did not check the criteria, and we don't know about the other 3. 2 people were not evaluated because they ended their lives another way, one by ending life-sustaining care. 1 was declared ineligible. 2 people lacked other forms of in-home assistance. They didn't want anything to do with life-ending measures at all. Only 1 person made a request for euthanasia that was made in writing, signed by the person and 2 witnesses, and dated. 6 people did not, and information is unavailable or doesn't apply to the remaining 4. 1 person was informed of the seriousness of their condition, the predictability of their death, the availability of palliative care, and the ability to withdraw the euthanasia request. 6 people were not, and we have no information about the other 4. In 1 case, we know the 10-day waiting period was followed. In 3 cases, we know it was not. 3 times the person took matters into their own hands without using the government program, and the other 4, no information is available or it didn't apply. Only once did a second doctor approve the euthanasia request. 3 people took matters into their own hands, took their own lives. 2 people were offered made by a professional, again contrary to the law, and 1 was deemed ineligible. The final outcomes for the people whose stories we collected are as follows. 5 took their lives, including 1 who stopped using life-sustaining care. 2 died by euthanasia. 4 were able to return to their homes from an institution and from a health crisis given adequate supports. 1 died of an undiagnosed condition. It's possible that something urgent was overlooked due to assumptions about the nature of their condition. 1 person received a psychiatric assessment, but any further updates have not been made public. What even this small amount of data tells us is that we don't know whether the law is being followed, including all the safeguards and eligibility requirements. More importantly, the choice to end one's life doesn't look like a choice at all. While the medical field and non-disabled observers have traditionally focused on cures, social services have not kept up by enabling people to establish and maintain control over their everyday lives. Therefore, we live in a society that is currently doing more to guarantee equality in death than in life. And contrary to the government regulations, people are being pressured to end their lives in a time of weakness. Death is serving as a cover and a catch-all to a variety of unaddressed issues. So more than anything, I hope the stats we gather serve as a wake-up call. Thank you.